presenting my paper on OCT macula and RNFL changes in high myopia and its correlation with fundus finding, axial length and B scan. Aim of the study to determine the OCT macula, RNFL, B scan findings and axial length in correlation with the fundus findings in the high myopia. Excuse me. Respond नहीं कर रहा है.
इनकी टाइमिंग भी ठीक करवा दी. टाइम चलो बढ़ा देंगे, कोई बात नहीं.
With continuing the material method, the study was mainly done in the KD Medical College in Mathura. Inclusion criteria: the age is between 6 years and 50 years. All patients with refractive error more than -6 diopter with the spherical equivalent, and patient visiting the hospital for the first time. The exclusion criteria includes any history of prior intraocular surgery, patient suffering from glaucoma, spherical equivalent less than -6 diopter, any history of corneal disease or having corneal pathology, any lenticular changes, any history of retinal diseases and having retinal diseases, any history or having retinal diseases, patient with the history of comorbidities, and signal strength of OCT less than 9/10 in either eye. The material method, the study duration was 4 months from March 2004 to June 2004 with a total of 98 eye. After taking history, the patients were dilated using 0.8 tropicamide with 5% phenylephrine. All patients underwent slit lamp examination before dilating the pupil. IOP recorded using NCT, wet retinoscopy after dilating the patient with PMT, and fundus examination using 90D lens, direct ophthalmoscopy and indirect ophthalmoscopy. The patient taken for the study underwent OCT macula, RNFL, OCT RNFL, A scan with emergent technique and B scan. The results include the sex distribution was mainly, a majority were males with 54% and female with 46%. Age distribution, the main age distribution was between 11 to 20 with the highest with 33%. Then family history was present in 14.5% and absent in 85.5%. Eye involved, the majority was bilateral with 98% and unilateral only in single case. The fundus finding, the fundus changes was present in 55% cases. The majority of fundus changes present are CR atrophy with 75%, tessellation with 76.6%, and temporal crescent with 63.3%. IOP, the majority was between 11 to 20 with 87%. Axial length was majority between less than 25 mm with 36.6 mm. Only more than 30 mm axial length was present in only in 11% cases. Refractive error, the majority of the refractive error was present between 6 to 12 diopter with 72%. Analysis of OCT of macula, normal altered OCT macula was present in only 10 eyes, that is 9.1%, with macular hole with traction only in one eye. Majority of, as we can see in this slide, the mean macular thickness decreases with the increase of the refractive error. Then again the foveal volume and the analysis of macula. Here we can also see the decrease in the macular total volume as the refractive error increases from 6 to higher above more than 18 diopter. Then result on at the analysis of macula and fovea volume by OCT. The number of eye affected with the macular hole, highest were with the active CNV with 37.5%. Fractional, the image shows the tractional maculopathy, active myopic CNV and the lamellar macular hole. Then analysis of OCT with RNFL, the majority of the least eyes was present in the red zone with the RPE thickness central, and the average thickness was total eyes majority in 37%, in yellow zone with 13%, and abnormal total was 50%. Then changes in the RNFL in red zone. The majority were present in the 12 to 15 diopter with the with the average thickness was 10 in 100%. Then OCT or RNFL in yellow zone. Then B scan findings, normal B scan findings were present in 68.37% with posterior staphylomas in only 6 cases, which consist of 3.6%. And coming on to discussion, the males were commonly affected, 54%. Highest incidence was between 11 to 30 years with 68%. And only 8 cases were present with the family history in myopia, and only 1 case has unilateral myopia, rest are bilateral. 55% eye shows the fundus changes like lattice, white without pressure or white with pressure with posterior staphylomas, PVD and RD. Then average inner macular thickness in superior quadrant was 271.4 with the plus minus 14.3, and according to that, the average macular thickness in the superior quadrant was 234.5 micrometer. And RFL thickness was found to, and coming on to the discussion, the RFL thickness was found to have the positive correlation with SE, which was statistically significant in the superior nasal and inferior quadrant, whereas in the temporal quadrant, RFL thickness does not show any statistical significance correlation with the SE. The highest correlation was found in the inferior quadrant with a coefficient of correlation of 0.58 with P equal to 0, and RNFL thickness decreases with the decreases of myopia. Then RNFL thickness was observed to have the negative correlation with the axial length of the eyeball, which was statistically significant in the superior nasal and inferior quadrant. The negative correlation between RNFL thickness and the axial length of the eyeball in the temporal quadrant was not statistically significant. The highest negative correlation was found in the inferior quadrant with the coefficient of error, with the coefficient of correlation of 0.549. And coming on to discussion, the central macular thickness was 227.41. The parafoveal region was observed to be thicker than the perifoveal region. The nasal quadrant was observed to be thickest, followed by the superior and inferior quadrant and the temporal quadrant. The macular thickness was found to have the statistical significant positive correlation with the SE. The macular thickness was observed to have the statistically significant negative correlation with the axial length. And coming on to the last. In the study, the retinal thickness. In this study, the retinal thickness increases in the foveal region and decreases in the macular region. The retinal abnormalities in the macular area can be frequent finding in the eye with the degenerative myopia. OCT can explain the patient visual complaints in the highly myopic eye and may even show the abnormalities in the asymptomatic cases. It can also detect some undetectable abnormalities on routine ophthalmoscope examination in order to avoid the advanced retinal damage.
Thank you.
Here you said that you're going to clinically correlate this with the fundus findings, and I saw that the posterior staphyloma you detected only on B scan. You did not mention about the posterior staphyloma in your clinical findings. Why I'm saying is that the RNFL thickness would also would be much thinner in patients who have a posterior staphyloma. So did you analyze it in that way, like patients with posterior, because the retina would be more stretched in that area. So those patients would definitely have a thinner RNFL.
Yes, ma'am.
So did you show that correlation? It would have been a very interesting correlation.
Sorry, ma'am. Available in
Okay. So because in those, if you had said no, that just simple without staphyloma and with staphyloma, that would have added to your study.
Primarily, what made you think about this study? What was the aim? Why did you study this?
So to establish the correlation between the axial length with the B-scan findings and OCT changes in RNFL and macular thickness.
Does it give any clinical significance that you should do in such cases, you should not do in such cases? What is the final outcome for the clinician?
Sir,
If some parameter is high, some parameter is low.
Sir,
So
this study is
what
for-
precautions he has to take?
Sir,
Or how frequently he has to see those patients? in which RNFL is decreasing, and how can you do it? The long follow-up is required, right? You have
So
follow-up.
long follow-up required
Yeah.
with frequent
Frequent,
visits,
yes.
with 6 months.
Follow-up is very short.
With 6 months frequent visits.
Also in your study, you did not mention the incidence of foveal hemorrhage or macular hemorrhage. The OCT you showed, where you said the patients had CNVM, they, sometimes on the OCT it's difficult to differentiate between in myopic CNVM and a hemorrhage. So did you do an angiography to confirm that it was a CNVM?
At that time, the fundus camera was not available.
Yeah, so because you just see that little elevation, many times it could just be a hemorrhage and many times it could be a CNVM. So you have to do angiography before you label it as a CNVM. So
Anyway, thank you, it was a good effort. Thank you, it was a good effort.